Thank you very much. And indeed, again, thankful to Professor Dheeman, to Seja and the entire team for inviting me for. Now, I would like to speak on a topic which is actually very interesting. Traditionally, I've always thought this is like a boring thing, PVT, what does it mean? I've understood that as my practice, increase, as my interaction increases with patients, more so when I started entering more into liver transplant as a hepatologist, I realized that this is a really troublesome entity. And the more you look into it, the more you do the imaging with better improved practice, you actually pick up more and more. So I'm not surprised by portal vein thrombosis in my patients, especially who are listed for a transplant next week. And this has been an experience, and I probably would share my practical bits more in this next 10, 12 minutes of talk before I rush to the airport. Now, in my talk, I'll speak briefly on type of PVTs, why it happens, and what on tumoral versus non-tumoral thrombosis, and especially challenges to diagnosis and treatment. Now, we are aware that portal vein thrombosis in cirrhotics, as the severity of cirrhosis increases, we pick up more and more PVT. And in liver transplant candidates, up to 1/4 of patients would have a portal vein thrombosis in any center. In fact, in my own experience, I would say maybe 30-40% patients have some form of PVT, but troublesome PVT, which is extended to the SNV or extensive portal-mesenteric thrombosis, that is not so common. And as a disease progresses from child A to child B to child C, the incidence of portal vein thrombosis increases. So it is directly proportional to the severity of underlying liver disease. Now, when we talk of portal vein thrombosis, we usually talk about acute PVT, we talk of chronic portal vein thrombosis, and we have an entity of tumor-related portal vein thrombosis, tumor-related. That is not really my talk today. My talk is mostly related to an acute portal vein thrombosis and a chronic portal vein thrombosis, how they manifest and what happens. Now, we must understand that there are certain nomenclatures we should actually be clear about when we talk of these events. We must understand what's recent PVT is less than 6 months, chronic more than 6 months, or persistent. It should be, based on the occlusion of portal vein. It can be completely occlusive, could be partially occlusive, minimally occlusive, or we can have a portal keratoma, which we are, all very familiar with. We can have a disease response related, definition, progressive PVT, or stable or a regressive. So all these things should be mentioned when a case is presented to us, by our fellows, and we say there's a portal vein thrombosis in a given patient in cirrhotic. These all should be taken into consideration. Now, generally, we are pretty much aware of why PVT happens in cirrhotics. Just to outline a few important points, most important factor is the total hemodynamics. Then we have systemic factors like inherited and acquired thrombophilic disorders, malignancies, hormonal therapy, autoimmune problems, and so on. The traditional Virchow's triad of stasis, hypercoagulability, and endothelial injury still stands true for this PVT. Now, as the severity of portal hypertension increases, liver is more and more cirrhotic. The portal flow, which is hepatopetal, it becomes hepatofugal. There's a stasis. This combined with hemostatic balance, which is altered in cirrhotics, we know that INR is a very positive representation of the correlation of the patient. Sometimes with increased INR also, we know patients have PVT. They actually have hypercoagulable state also. There's an imbalanced hemostasis. So this is very exciting and interesting. And therefore, we will stop relying too much on INR in our patients who are going to transplantation, especially in theater and all. We would all rely more on their thromboelastogram or time. Then we have this thrombophilia, which Akash was mentioning. There's several, acquired or genetic thrombophilic disorders which can contribute to hypercoagulability. And then there is endotoxemia. This can be from the gut microbiota, or it can be because of other factors leading to more portal vein stenosis and leading to portal thrombosis. But common factors which we must understand in our practice, those who have advanced from cirrhosis, child B to child C, high grade of varices, where the portal vein flow is getting low or static, large collaterals which are shunting the blood away, injudicious use of non-selective beta blockers, again, lowering the portal flow, scale from the varices will be much, post-mortem and so on. So some of the factors which contribute to a portal vein thrombosis in a cirrhotic. But I think that clinicians should be aware of this very basic classification, which was given in 2000. I think it came from Birmingham actually. This is what we use in transplant presentations when our surgeon or our fellow will present a case, he'll say, sir, PVT is level type 2. So we should be very clear about what is type 1, type 2, type 3, type 4. So this is type 1, which is less than 50% from the portal vein in trunk, then it is more than 50% occluding completely. Partly antiperceivable is portal type 3, and grade 4 is when it occludes the cervix completely. But as far as hepatologists, we must understand that this is an anatomical functional classification, which was very well produced by Professor Serene and Patrick Kamath, which was in, I think, 2016. When we consider the site of PVT, the presentation, acute or chronic, look at the underlying liver disease, look at bigger portal venous system occlusion, and what is the extent of portal system occlusion, which is very, very important. So based on these criteria, you can actually divide it into an anatomical versus functional, portal vein thrombosis, and then you subdivide it further. And then recent or chronic. So I'm not going to go into details. Anybody interested can read this excellent article in gastroenterology. But yes, as hepatologists, it is important for us to know because this also gives us a flow of the natural history of portal vein thrombosis in cirrhotics, which you would understand that despite PVT being there is a chance of spontaneous resolution in 31 to 70%, regression, stable disease, and progression in about 7 to 10% patients. And then we have a group which is asymptomatic or there's a symptomatic group. So why this is needed? Because this sort of algorithm allows us to decide a therapeutic approach to these patients. I'll come to this slide in later part of the presentation, which says how you tackle these patients and how you approach this portal vein thrombosis. So what are clinical consequences? Some patient who's stable cirrhotic following us in OPD comes to us with large ascites, or somebody comes to us with vessel bleeding. We almost always do an ultrasound Doppler and look at the portal vein system, and they can be having a portal vein thrombosis. We are very well aware of that. So standard teaching, portal vein thrombosis can lead to a decomposition, can lead to ascites, vessel bleeding, or a liver decomposition per se, depending on the site and extent of the portal vein thrombosis. And please understand that PVT is not a computational liver transplantation. So this is very clear to me now. We are aware that advanced early grades of PVT make the surgery more complex, sometimes make the outcome bad or not so good. But yes, I have seen that over the last 2 decades, our surgery colleagues have tremendously developed their techniques in dealing with portal venous thrombosis. And in fact, if I tell them that there's a large thrombus occluding PVT completely, they get very upset that why not listing? We can handle it. It's like a challenge to them, So 2 things our surgeons don't like. One is that if you tell me they will believe this or no, we can handle it. Otherwise, if you say there's a portal vein thrombosis and it's too extensive, no, let us do it. So they have jump grafts, they have thrombectomy, we have preserved vascular grafts from other patients and so on. Essentially, all kind of conveys that PVT no longer is a contradiction, but we know that it increases the liability of a transplant surgery. So clinically, yes, it can be acute, and as an acute ascites or a chronic, which we are well aware as I was speaking, and it can present with a portal cavern or a portal velocity. This is not always very important. This is one slide I want to just stress 2 minutes on it, because if somebody has a portal vein thrombosis, we must be very sure that there is no underlying HCC, underlying malignancy. Sometimes I've seen that the tumor is so small, you may miss it actually. So this A1 criteria was given beautifully by, not too sometimes back, where 3 of the following criteria, 1,000 expansion, thrombus enhancement, new vascularity, and adjacent to a SCC. If 3 out of these 5 criteria are present, then you can say it's a tumor thrombus and with 100% sensitivity and 90% specificity. And if these criteria are not fulfilled, then you can say that it's a 100% negative predictive value. So this we are all aware. So we are very well aware that if there's a portal vein thrombus, even in HCC patient, we say this is a bland thrombus, because immediately the prognosis of a patient changes when you consider transplantation, if it's a portal vein thrombus or a bland thrombus. So these criteria are very useful, and our radiologists are very apt at picking up. I mean, Dr. Basil will there, I think he is the best person to answer this, but yes, we can do that. Now, management of portal vein thrombosis in the last section of the talk. Now, as Akash was saying, anticoagulation has a huge role, but I will tell you, I've always found it very difficult. I sometimes find that the exercise of PVT and cirrhotics is so futile. Why am I at all discussing it? I had a patient, a young patient who's a senior resident in hospital in Delhi. Something he came to me. His relative had again very young boy, 32, had first time treated cirrhotic, had large varices, grade 3 with red vein signs, and he got almost near complete occlusion total. Everything new, all things happening in 2 weeks' time. No history, no pattern, nothing, no pain, nothing. We would like to do something for it. Can you anticoagulate this patient? Large varices with red clear signs. Well, I will not do it. It's very tough. So what you do, you try to deal the varices first, wait for it, eradicate, and so on. So it's not so easy, when you actually practically deal with it, because there is a risk of bleeding when you are treating these patients, right? Either from varicose or from gastropathy or from other sites. But yes, if you can treat in the correct patient in the correct way, you can recanalize the portal vein. You can prevent extension, which is more important. Prevent extension of portal vein thrombus into SMV. And if patient is on wait list, yes, it is very useful because you make the patient stable by using anticoagulation. So in these last 2-3 slides, so how to manage portal vein thrombus in cirrhotics? Well, whom should we treat? Those potential, liver transplant candidates, yes, on wait list surely, who come with acute portal vein thrombosis, you must treat, whichever way you want to do. Symptomatic acute occlusive PVT, you should treat. Progressive disease from a stable portal vein to extension to SMV, you should treat. And those who have signs of mesenteric ischemia concerning, you must treat. When to treat, when once you confirm the diagnosis, well, you should not delay too much and try and treat as early as possible. As I said, if there are large varices, they are the biggest impediment to your treatment because you don't want a bleeding, bare exposed treatment. So you try and eradicate them or beta blocker, whatever it is. And of course, so you should do an endoscopy before you embark on anticoagulation in these patients. What anticoagulation should you use? Well, as again my colleague has said earlier, you should decide on whatever you do. Well, low molecular heparin is still, as a first-line therapy, which you would like to do. And why will you treat? Because I know there is a benefit to these patients if you are treating them. Acute, absolutely there is a benefit. In chronic patients, yes, if you can make them stable and they're on wait list, you don't want a thrombus from a partial portal vein thrombus extending to a full complete occlusion in SMV and then jeopardizing this patient's chances of undergoing a good transplantation surgery. And how long to treat? Those who have thrombophilic states, JAK2 mutation positive or something like that, I would say indefinite treatment probably for them. Otherwise, yes, minimum 6 months, and then based on their clinical course, how they have responded, you should do a follow-up imaging every 3 months as per the thing. And once you stop the treatment, you should not leave the one from follow-up and try and do regular imaging every 3 to 6 months to see that there is no recurrence or extension again. Complications we have discussed before. So this is the earlier slide I was showing. So when you have a portal vein thrombosis in cirrhotics, stable disease, you're following up. Progressive disease, inherited thrombophilias, you have options of anticoagulation, TIPS, transplant, varices have to be dealt with, and sometimes big collaterals, BR2 and so on. Acute, yes, you should definitely treat these patients and see that you're really able to recanalize them at the earliest. So this is an algorithm which one would like to follow. Once you detect portal thrombosis, you surely should exclude a tumoral thrombus, should look at the anatomical extent. I would say that anatomical functional classification is very useful for us. Look at underlying liver status, child ABC, thrombophilic disorders, so on. And this flow chart then allows you to take a call as per the patient's condition. And yes, whenever there's an indication and requirement, I mean, when we have somebody like Dr. Bajal around, we are very, very confident that yes, we can deal with any sort of complication, any sort of complex portal thrombosis, and recanalize them and have a good outcome for these patients. So I'll stop here, and any questions, I'd be very happy to answer. Thank you very much.